Well, hi everyone, and welcome to the next episode where I'm joined by James and Claire, two good friends of mine, both doctors who have worked doing voluntary work in Malawi, and they went off in October 2013 to May 2014. So for 7 months they were in Malawi. So, hi guys, welcome.
Hi, thank you.
And I'm really fascinated to know about your trip and what happened, and so tell us a bit about what it was all about.
Okay. Well, Claire and I, we both had took some time out of training, and we decided to go and volunteer working in paediatrics in Malawi.
Both of you were doing
both
paediatrics,
of us, yeah.
right.
And
you'd had a lot of experience with peds before you went.
No, neither of us had any experience. We'd done our 2 years of foundation programming. We'd done had a little bit of peds experience through emergency training, but nothing really formal other than that.
Right.
Yeah.
Cool.
I had a bit of a background in tropical medicine. I did the diploma in tropical medicine and hygiene in Liverpool.
Liverpool one.
Yeah,
right,
and that was
great.
a few months prior to going out.
I hear very good things about that.
Yeah, it's good. It's well worth doing.
Right.
Well worth doing in Liverpool rather than London.
Rather the London one. Right. I did it at the London one. Well, I did the diploma of tropical nursing at the London one. Yeah. But anyway, carry on. Sorry.
And we worked full time. Well, even although we didn't have a background in paediatrics, we got stuck in a steep learning curve, very well supervised job, a lot of teaching, and I think partly because of the range of diagnostics you had and the range of therapeutics you had, the way you approached medicine was probably slightly different than what you would do here in the NHS.
Right.
Yeah.
So when you say that, you mean it was more kind of going by your clinical examinations rather than doing tests and things.
Yeah, which is largely what paediatrics is anyway, I think.
Yeah.
Even here, but we did have some limited tests, and we were lucky to have things like blood cultures, which we didn't have access to in other parts of Malawi.
Right,
Yeah.
so that was considered quite a luxury to
Yeah,
have that.
yeah.
So I'm quite interested in the kind of population of the people you were looking after. These presumably were poor people who had quite a lot of chronic diseases, that kind of thing.
So we were working in a tertiary centre in Malawi. It was one of the two biggest hospitals in Malawi, and Malawi is one of the poorest countries in the world. And we would see everything that was referred in from the district generals, as well as what was presented within the surrounding city, which was Blantyre.
Right.
So we'd see a huge range of both what was very common things like pneumonias, meningitis, TB, and then you'd see more specialised diseases that would be referred in.
What kind of things would those be? Are these like tropical diseases?
They're a whole range. So yes, tropical diseases, neurological conditions that there were quite a large part of it, long-term chronic conditions as well that couldn't be managed elsewhere, epilepsy. The district generals don't particularly have the medication to help manage these, nor the resources, facilities. So just by being in a tertiary centre, they had the means for outpatient clinics and try and attempt some kind of follow-up.
Right. And these people, is everything free for them, or are they paying for some parts? Or
for children, most of it's free, but I guess you need to consider the transport costs.
Yeah. Okay.
And both ways.
Yeah, of course.
So that's a big factor, and the opportunity costs. So if you're taking a family member out of their work, then it's loss of income as well as an extra burden of cost as well.
Right.
So there's that to factor in. And it's interesting to when you reflect back on what the burden of disease was, how much of it was your infectious disease and how much of it was your long term, like Claire was saying. You don't think about people having diabetes or heart conditions or cancer, but they are
a significant part of the workload.
Yeah, absolutely.
Yeah, you don't
think
of that at all.
Yeah.
No, it's interesting.
Yeah.
Wow. And presumably the living conditions for these people were absolute poverty for some of them.
For some, I mean, I think I would say the majority of people we live on, I'd say they were on the less than $1 a day kind of lifestyle, well, living conditions. They're poor, and life is difficult for them, so their living conditions are therefore quite difficult.
Yeah.
And it is a struggle just to find food.
Yeah, wow. And what do you think, I know you're talking about the equipment in the hospitals and things like that. What about the general level of care that they were getting whilst being in the hospitals? How was that, and how did it compare to that over here?
The vast majority of staff there were very dedicated. They're hardworking, but a lot of the time you notice how difficult it is for them to make a living, and the sort of working patterns that they put up with to make it worthwhile for them. A lot of them are very tired. They're very demoralised staff as well.
Presumably they were earning peanuts as well.
Yeah, essentially.
The culture within a hospital is so different. So the culture it was an acute hospital, and the culture is that you expect people to die rather than to live. So there is no incentive. It's extra work if someone is unwell. There's no motivation to try and improve things almost.
So
there are no implications.
So did you find yourselves working, kind of having to work against that and trying to almost educate a different style of...
We were aware that we were just another set of foreign doctors, who are coming in for a few months, and there were several who have been before, several will come again, and I think it's having worked in other healthcare settings in sub-Saharan Africa, and you become aware of that sort of perception that others may have of you. So we didn't want to be that rich white man
trying to tell them what to do.
Yeah, exactly.
And the thing is, it's even the 6 months you were there, it's too short a time to make significant changes in those kind of ways anyway.
Yeah. You do see there are migrant doctors who come from Europe and North America who are working there long term, who are able to have more of an input, and they provide a very valuable they bring a lot of valuable experience to the place, where you can bring good practice from overseas to Blantyre, to Malawi, not just medical staff but nursing staff as well. And I thought one of the big bottlenecks in providing good quality care was good quality nursing.
Right.
What does that actually mean? And coming from a medical background, we take good quality nursing for granted.
Right.
And only when you see poor quality nursing do you really appreciate how valuable nursing is for good quality care.
So, can you think of any examples to kind of demonstrate to the people listening what?
The night shift culture, probably. So the night shift, you do it to sleep,
right?
Almost. It's a struggle for any kind of action to happen overnight. So if someone's unwell, there is no way you can get any observations 2 hourly, 4 hourly, let alone anything.
Right.
Less than that.
Yeah. And that's just observations, but when someone's on an hourly blood sugar monitoring chart,
it's pretty serious.
Yeah. You have to almost hope that the parent or guardian of the child has a bit of nous about them, can prompt the nursing staff or actually do some of the observations themselves.
Oh my God.
Or when you have an apneic child, make sure that the mother stays awake to prod them to actually get them to breathe again.
So it's like here you don't realise how much you're relying on your nurses to just tell you how sick your patients are and keep an eye on them, really. Wow.
But one of our consultants there, who was the head of department at the time, and what he said I think is really valuable, and he said we can't do very much, but then what we can do we must do well.
Right.
And it's just the little things that you must learn to do well, and at all times have patience with the staff there, and don't lose your temper with them as well.
Indeed. Wow.
It's probably taught us a lot it's taught us a lot. That's allowed us to bring it into our work here. Let's just re-emphasize that. And it wasn't like us taking our skills out there. I mean, we were quite unskilled, really,
right.
in terms of our paediatric knowledge. But we learned a lot.
Brilliant, fantastic. And any other stories? I mean, I know you've got quite a good story. James has got a good story about a needle stick injury that he got which is maybe slightly more unusual needle stick injury than most people have. So do you want to talk us through that one, James?
It was a very poorly child. I was on call, and they were very, very dehydrated. The background was I think they were a 2-year-old child. No, maybe younger than that. I think probably a bit younger than that. Actually.
Were you there at the time,
I
Claire?
can't remember how old.
No, on the phone.
Right.
Younger than that. I think maybe a year old to 18 months old. Severely malnourished with HIV, being treated for TB as well, dehydrated, and couldn't get an IV access. So I decided to try an an IO access.
So that's intraosseous access.
Yeah, through the tibial, top of your tibia, tibial tuberosity.
Right.
But we didn't have any IO needles. So
Right.
what we used were big green needles, which are quite flexible and a bit of a wiggle to get into the bone. And in trying to wiggle it, reposition it, I pushed too far, and it went through the back of the leg into my finger. And this poor patient had a very high viral load, HIV. So naturally, it was a little bit worrying for me to, after bleeding and sort of quickly washing my finger, having to obtain post-exposure prophylaxis for it.
Right. Which you were able to do.
Yeah. So, good tertiary referral centre. PEP is available, but there's a bit of a who provides it. Bit of we took a very roundabout route to actually finding it. Yeah.
And it was triple therapy, not quadruple. Was it?
It was double
rather than triple.
Right. Okay.
And it wasn't quite what
you'd got here. But
we had a deliberation of should we buy PEP before we went out there, and we made a decision to not get it because we'd been informed there was PEP available should you need it.
Right. Yeah. But you don't have HIV.
No, I tested
Right.
negative.
Okay.
There was no Hep C testing when we were there, so that was a bit of a wait.
Right.
To find out. I mean, it's a very low risk for Hep C. Can't really tell, but I tested negative for that.
Okay. Yeah. But the child in question at the time,
Unfortunately, didn't do very well.
Right.
There's a very high mortality rate with any child who's malnourished.
yeah.
I think that particular ward you worked on that ward. It's very, very high mortality rate.
Yeah.
Yeah.
Okay. Well, I think we'll leave that there for part one. Unless there's anything else, any exciting stories that I suddenly need to know about, then I think next part two we'll talk more about preparation for protecting themselves from various tropical diseases and travel health, and how they went about doing that, and also a bit about your adventures when you went travelling at the end of that, was it?
Yeah.
Yeah. Okay, excellent. So thanks very much, and we'll see you in part two.